Good afternoon, Dr. Ari Deuk-Machen. We're here at the Deuk Spine Institute and Surgery Center of Viera. We're getting ready to start our last surgery for the day, and this young lady is going to have 3 discs repaired. And as you can see, her discs are pretty collapsed. There's also some twisting of the spine going on. So I have to try to get to those places and keep her comfortable. Shot? Blood pressure is could be a little bit better. Let's drop the table an inch. All right, so the first step in doing the surgery is to get down to those discs. And to do that, we're going to use a needle. So our first disc we're going to access is L5-S1. Are you comfy? Alrighty. You let me know if you're uncomfortable, okay? Yeah. There's quite a distance from the outside world to the place that we're trying to get to. We're trying to target what's called the annular tear, which is where the herniation comes out of. And everybody's annular tear that causes a herniation, that causes back pain, those herniations and tears are always in the back of the disc. All right. So we're trying to make our way to the back of the disc down here at L5-S1. Shot? Shot? So we're encountering the facet joint. This is a hard, bony thing. Let's get an AP. And I would love to actually bring the table up half an inch. Good. Shot, when you're ready. Our trajectory looks really good at 5-1 on the lateral view. All right, so I'm too medial. I need to be more lateral. And that's fine. So I'm going to redirect. Let's go back to a lateral view. Otherwise, we were doing pretty good. So based on that AP view, I'm too medial. I'm actually hitting the facet too medial towards the midline. So I need to be a little bit more lateral. Shot. 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 Would love to see a little more detail there, Jordan. Shot. In other words, first of all, I think your oblique is off. Your orbit is off. You got to reorient. Shot. Worse. More. Correction. More. It's getting better. Howsy wowsy. All right. Let's, now I think it's getting worse. Go back. I think we overshot. Could be wrong, a little more. All right, let's go. Now that's probably okay, but let's go with an AP and see where we are. I'm hoping we're right by the foramen. So L5-S1 is usually the hardest disc to get to. It will be one of the hardest in this case. The hardest is going to be this and L4-5. Just almost at the lateral border of the pedicle. So let's go back to the lateral view. Yeah, we got a massively rotated spine. Shot? You have any pain? No? Shot? Oh, well, there we are. I'm a little lower than I want to be. Always seems to be the problem. Shot? At 5-1. Give me an AP. Yeah, we've got to get a better zoomed in view than that. I got to tell you, Jordan, we've got to get into 5-1 a little bit better. Shot? Yeah, we're right there. Oh my, what a spine. Lasagna. You can make me a lasagna too.
You want to make Dr. Deuk one too?
You can make all of us a lasagna. Bring
Everyone
it
here
in.
gets a lasagna.
Oh, you're very sweet. You're very sweet. You're hungry, I take it. All right. I need to be a little bit more north. Shot? Yeah, of course. I mean, me too. Our neurosurgeon's a foodie. Shot? Right? Shot? You know, my dad was a doctor. I don't know if I told you. And his patients used to bring him food all the time. Shot? So I'd like to get a little more medial and a little more there. There's the facet. I'm literally scraping against it. So, shot? Uh-huh. Shot? Oh yeah. Shot? Where do you feel it?
Left leg.
How far down? Well, that's why we have you awake. All the way to your foot? Is it gone? All right, so we got to do something to improve that image. Is that really the best zoom in you can do?
Yes.
I thought we could magnify it. Let's try to, oh yeah, that's better. All right, now let's try to get that, I don't know what it is. I know there's a lot of scoliosis that we're dealing with. Let's go AP. You can see we're right there. Nothing down your leg, right? Yeah. I mean, you can see the facet. Or just lateral to it. I want to be a little bit more medial. I may have to start more lateral. That's what I'm going to have to do. She's got numbing all around here. All right, let's try again. Lateral view. You'll have to zoom out a bit. Shot. 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 Are you awake? Are you comfy? Shot. Huh?
She said she's got her man, the anesthesiologist.
Yeah. Can you come south a little with the fluoro because I think we're off a little bit. I just want to make sure I can see everything. All right. So we've really got weird anatomy there at 5-1. You see that? I can't even make out the pedicle, the foramen. I can't see anything. So I would just play with it until we get it. I don't know that that thing is going to do it. It's probably more arc. What did she say?
Can we bring the pedicle over?
No, no. Yeah, it may be better. What do you think? Let's try that. Let's get an AP. See where we are. So in case you didn't know, her spine has got a lot of scoliosis. All right, so we're kind of off of the facet. Shot? Shot? Any pain? Nothing? AP? I mean, the trajectory is beautiful, right? Just a shot right down the disc. The question is, are we medial enough to get to where we need to be? It looks okay. We're right by, see the pedicle of 1? So we're kind of in the right spot. Let's see. Nothing? Just very collapsed. Where?
Right where you are.
In your back.
Yeah.
Yeah, that doesn't surprise me. That's one of your bad discs.
That's the pain that she has. Right there.
That's where you get your pain?
Yep.
All right, well, Solon's discogram. Shot? I'm going to have to let her relax before I can get in there. It's not going to be fun. Shot? All right, let's do 4-5. Hopefully have a little better luck. Let's do some local first. Blood pressure, where is it? I can't see it. The cuff is going up? Or the pressure's going up? You're funny. Very funny. All right. So we're making our incision. Next stop is the annular tear on the left at L4-5. Shot? All right, so 4-5 is pretty collapsed. Shot? Let's see what we can do to clean out that foramen. I don't know, bring the collimator down a little bit. Bring the left down. See what I'm talking about? The collimator? Got too much air or soft tissues back. Yeah, that's fine. Go ahead. Yeah. Luis is just looking at me like, what are you thinking? Shot? Right, Luis? Shot? I love your optimism. I'm feeling it. Shot? Where do you feel it?
Right in the back.
In your back. All right. Shot? Shot? Let's go AP. So as we enter the foramen, we want to be sure to be underneath and medial to the exiting root. We're a little more lateral than I want to be. Let's see on the lateral view. So I need to be more medial. Shot. Shot. Shot.
You feeling that? Where are you feeling that? Where?
Shot.
Right where he's working, huh?
Yeah, we're not even near her foramen yet. But shot. Now we're getting closer. Shot. Shot. Want to make sure I come in low enough. Any pain? Shot. Where? Back or leg? In your back.
Yeah.
Give me an AP. Again, I'm right on the disc, but I can't get in because it's so collapsed. I can feel it. Yeah, we're right on the disc. Right on the disc. So I'm going to try one more. Are you comfy?
She has pain in her back.
Yeah, right where you typically get it, right?
Yep.
Mm-hmm. Yeah. One more time. Mm-hmm. All right. Miracle of miracles. Anybody watch The Fiddler on the Roof? You ever watch The Fiddler on the Roof? You okay?
You okay, sweetheart? She does have a chronic cough. She told us
Okay.
about that, and she's seen many doctors about it.
It's not lisinopril or some ACE inhibitor.
No,
Not that easy.
it's not reflex esophagitis,
Mm.
regurgitation problem. No, they checked all that.
Sinus, drainage. There was one medication that worked. I need to see 3-4 better.
Tussinex, they took it off the market.
I understand. Yeah, what's happened was people were making bad drugs out of it. I think that's probably as good as we can get. Maybe you can. I guess that's fine. Shot. You're doing great, Shot. Your spine is not making it easy for me, Shot. Huh? Your spine is one of the hardest I've ever dealt with, Shot. Shot. And I've dealt with a lot of them. Shot. Shot. All right, we're getting close. Shot. Shot. AP. So what's making this spine so challenging technically to get to the discs is the collapsedness of the disc spaces. They're severely collapsed. And I need to be more medial. And look at the bone spur right there. It looks like a giant parrot beak. So, she doing good? I have to be over more medially. I'm hitting something bony. Huh? I appreciate you saying that. I know. Shot. 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 So far away. Shot. Shot. Get an AP. How's blood pressure? Jeez. That's incredible. I'm not even at the disc. I'm gonna have to come more lateral. Okay. I'm gonna have to try a different trajectory for that one. Let me have a knife. Oh yeah, local. There's epi in there, right? Yeah. Huh? This is very little in this injection. I wouldn't need to give any if the blood pressure was lower. I mean, right? You're driving it out. You funny guy. So I'm going to have to attack L3-4 more laterally. Shot. The problem is, as I attack L3-4 more medially, I'm encountering that ginormous facet joint. Shot. See where we are. And that facet joint is deflecting me. Shot. It's deflecting the needle to where I cannot access the disc. Shot. It's literally pushing the needle sideways. Shot. Shot. You still comfortable? Shot. Any pain?
How you doing? You okay?
Shot. Shot. All right, so I'm pretty close. Let's get an AP, see where we are. worked. Dude, that's awesome. I'm so happy. Yeah, that's interesting stuff. So for those of you who really like this stuff and want to know what I did, I actually started more lateral, but you have to be careful not to go too lateral, and snuck underneath that abnormal bone. So, shot. Oh, we're right there. Oh, hold on. Don't get too excited, Luis. Luis is like, yes, we can do a discogram finally. On the one disc we didn't think we'd get, right? All right. No. I wish we could get L5-S1 for a nice discogram, but I just don't see that happening. So we'll be lucky if we can fix these. Okay, so we're the best we can. At L3-4, we're inside the disc. And at L4-5, we're at the back of the disc, and L5-S1, we're at the back of the disc. And the best we can hope to do is to get into the disc when she's asleep. Just basically put a guide wire and go for it. So I'm going to start with L3-4. All right. Are you comfy?
She said yes, sir.
All right. We're going to put you to sleep soon, okay? Are you having any pain? Huh?
No pain.
All right, good. How bad is that on a scale of 1 to 10? All right, is that where you typically get pain? When you wake up, that'll be gone. We can put her to sleep because I can't discogram the other discs. We're not in. All right, can you count from 1 to 100 out loud? 1 to 100. 1, 2, 3. All right, so this is L5-S1. Are you guys going to change the light? L4-5, L3-4. This young lady has 3 bad discs, and the only one I got the needle into the disc far enough to test was this one. What was that, a 10 out of 10? Yes. She had 10 out of 10, concordant. We couldn't test the other 2 because I can't get the needle into them far enough with her awake. So we're just going to do the first laser at L3-4, which we know for sure is causing her pain. Then we're going to move down to the next 2. All right. Shot. So there's the guide wire. And I'm going to remove the needle. Now, somebody was asking me what's the difference, Shot, between the Deuk laser disc repair and something called an IDET or intradiscal electrothermoplasty, or even a percutaneous procedure with a laser. So percutaneous procedures are done through the needle. We're past that. We just use the needle to access the disc and then to do our discogram, but the actual surgery is not done through the needle. A percutaneous surgery is done through the needle. This is a real surgery procedure. It's far more complicated than a percutaneous procedure.
IDET didn't have a higher failure rate, I think, the IDET.
Yeah, IDET was, you know, a lot of pain doctors were doing it for a while, but it really, I guess, didn't have good results. This was before I got into pain.
Right.
And, you know, insurances stopped covering it because apparently it didn't work. I don't know. But literally all the doctors would do is put a needle in and then put the laser down the middle of the needle and zap it a few times and they were done. And that's not what we do. We do a far more complex surgery. Most importantly, the annular debridement. We can treat not just herniated discs, but degenerated discs, like this one. And annular tears. Shot. Uh-huh. Shot. Let's get her nice and comfy. Shot.
Give me some more, Gerard.
So the first step is to gain access to the disc and a tear of the disc with the herniation with a transforaminal approach using a needle. After that, we put our guide wire and bring our dilator. I'm going to wait till she's a little bit more asleep. Uh-huh. That's propofol. Come on. Admit it. Admit it. Nice. Tell me when you're ready.
How you doing, sweetheart?
So we need her comfortable enough to open those bones and get in there. Shot? Yep, and it's happening right now. So by her being asleep enough, we can actually get into that disc and fix it. Shot. And as I'm going in, you can see the disc space spreading. Uh-huh. Beautiful. Very nice. Hey, any questions from our audience?
No, sir.
Why don't you show the audience our video of why do discs cause pain? And I'll give you a hint, it's inflammation. That's always the case, 100% of the time. Inflammation.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Ay, caramba.
And bring more tube sets to it, please. Yeah.
You want the wet?
Yes.
Just don't want to crush the holes. If we can avoid it. Here, let me see. Where's the bigger vice grip? Got it. Shot, got it. Shot. See if those holes are still working. Looks crushed. Crushed. Yeah, it's crushed. It's crushed. Fuck. How much are those? Buy some more. How many do we have? Let's get more. I just hate to be run out of something when we need it. Damn. Just sucks. Are we back?
Yes, sir. We're back.
Huh?
Yes, sir.
I can't hear you, man. You've got to raise your voice. We cannot hear you. I don't know why we always have to tell you that, Kevin. You got to figure out what the sound levels need to be. Welcome back. We are in the L3-4 disc. It literally was so hard to get the dilator out. It broke. We had to use a vice grip. So I don't know if you all saw that, but you know, in the end, you have to do what you got to do. These are all pieces of herniation. Isn't that amazing? Such a collapsed disc, and yet there they are. You think there's no way this woman has any disc material left, but in reality, it's there. What we're seeing is a very red, inflamed bone, and there is the annular tear at the top. But I want to show you guys this, what we had to do to get the dilator out. Let me show you the dilator. It's pretty incredible. Can you see that? It's a new one. Where's the old one? Where's the old one? Oh, I got it. Don't get close. All right, can you all see this?
Yes, sir.
All right, let's see. Just leave that. Leave that. Yeah, leave it. It's not going to do any harm. It's fine. Can you see this right here?
Yes, sir.
You see how it's crushed right there?
Yes, sir.
Yeah, that was the only way to get it out, was to use a vice grip. All right. Let's clean this thing up. Now, the good thing about degenerated discs like this is there's very little annular tear that needs to be cleaned up, but that little bit does a lot of pain. You saw that she had a 10 out of 10 pain. That's it right there. Once I zap this little bit of tissue here, that should fix her pain at this disc. I still have the other two to do. Hopefully we can get them. That's one of the things that amazed me, is that how such a little area of tissue could actually cause so much pain. But it does. And I've done this so many times and seen the results work that it's astounding to me. Watch my needles. Don't let them come out, please. So you can see the gap between the bones. That's actually the disc space, but there's very little to no disc material left. It's literally just an empty space, and that's not the problem. People always think, oh, you got to put a cushion in there. You really don't. I can't tell you how many of these discs I fixed without putting a cushion. This is the back of the disc right here. This is where all that pain comes from. This pain fiber is just concentrated in this area right here, in the back of the annulus where the tear was. So this disc will be done in about a minute or two. And she didn't have anything weird like a migrated disc on the MRI that I saw. You didn't see anything, right, Luis? Just about done. I'm going to pull back a little more. You can see some veins there. Those veins, I'd like to try to avoid opening them. They're part of what's called Batson's plexus. Batson's plexus, that's a bone spur. Batson's plexus is a group of veins that live in the spine in the epidural area.
That's the channel by which cancer
Yeah.
metastasizes to prostate cancer.
Yeah. And the famous question in medical school is, what's the name of the veins that cancer uses as a highway to go through and metastasize to the spine?
You didn't think I knew that?
Of course you know that. Everyone knows Batson's plexus. Every doctor. All right, just about done. That's it. That's all bone spur, nothing causing pain, sitting in the middle of the disc. And we're pretty much done here. Like I said, degenerated discs are hard to get to, or hard to get into, but once you get in, they are usually a little bit quicker than some of the softer discs. Let's see. Yeah, somehow we move the tube. The nerve root's going to be right up in that fat right there. A little bit more disc right here I want to work on, and then call it a day for this disc. Done. Now we're outside the disc looking in. A lot of inflammatory tissue here, but that'll all go away. Laser off as things start to heal. Irrigation. Yeah. Light on.
Lights on, please. Thank you.
Yeah, I don't need that right now. So, will you guys remember, Flynn, will you remind Luis we need to buy some more of these dilators? Please, I don't want to ever run out of them. And this kind of stuff happens with the tubes, the dilators. They get crushed from time to time. They are stainless steel. They should be. They may be titanium though. That's a great question. They do feel a little bit like titanium to me. You think they're stainless steel? Yeah. Luis says stainless steel. Surgical steel from Germany. All right. So we've obviously had to get a new dilator, which we'll use for the next disc. But we're probably going to have the same problem. All the discs are collapsed. Any questions from the audience?
No, sir.
Why don't you show our audience the video of how the Deuk laser disc repair works? The animation.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Right, we were just talking about how God can challenge each of us every day, and sometimes I feel like God laughs at me with cases like this. Like, good luck. Let's see how much harder we can make it for Dr. Deuk. All right, Sean. So I'm just gently twisting this dilator with my hands and applying a little bit of pressure as I move it down towards the back of that disc at L4-5. And I know this is not going to be an easy one, because I know that disc is so collapsed, I can see it. And it's going to take a miracle to get in there. And that's what I mean. God just laughs at me sometimes, saying, you think you can get in there, but you're not going to. Not without a miracle, not without divine intervention. So I will do my best, and as I always say, God willing, it'll work. And if it's not meant to be, it won't. So this disc is really, really badly collapsed. Let's get an AP. And I want to line up the dilator at the back of that disc to give me the best chance of getting in. Now we're there. At least we're in the right spot. So let's go back to a lateral. We actually were able to do the L3-4 disc. We finished that. And now we're focused on the next disc down, which is L4-5. And honestly, it's a tough one, but I'm not going to give up without trying. Shot. I know this patient's in a lot of pain, and if we can get into this disc, then I believe this disc is a source of pain. Shot. And the reason I say that, we had a patient earlier today who we were unable to get into one of the discs. And it turned out because the disc was already fused. It fused itself. It's called an auto fusion. Auto meaning by itself, without anyone intervening. I didn't fuse the disc, but it was already fused because his inflammation was just so bad, and he had been dealing with it for so long that it was a divine auto fusion. All right. Here we go. Let's see if there'll be any divine intervention now. Shot. And then pull it. Shot. We're in the right spot. Honestly, it feels just so collapsed. It doesn't want to open. It's starting to open a little bit, would you say? Am I the only one seeing that? Shot? Maybe? Just... Shot? There it is. There it is. Shot? Wow. Let there be light. That light is air. That light is air. That is called the vacuum space phenomenon. When a disc gets super dried out and collapsed, it actually somehow creates a vacuum. Nobody really understands why, but negative air pressure. But we're in. And I'm glad we are. We could do a discogram if you want, but there's really no point. All right, so we're going to bring our tube down as we did before, and We're gonna hopefully not destroy more equipment. Keep her nice and comfy so she doesn't tighten up. One of the reasons I was able to do that way, for those of you future endoscopic spine surgeons, you notice I wasn't in the disc space shot. I was outside with the needle and I was outside with the guide wire, but I knew that the path of least resistance for the dilator could be the disc space, could be. And you gotta say, well, where are you gonna get less resistance, the disc space or the bone? Now in somebody who's osteoporotic, it could be the bone. So you gotta be careful that you don't start sticking your dilator into the vertebral body. If you do, it's not a big deal. It'll heal, but you don't want to keep going if that's what's happening. You want to back out. So as you're hammering your dilator in, are you in the disc space or are you in the vertebral body? And that you don't know. That's why you got to watch to see if the disc space opens up. If you're in the vertebral body, your disc space won't open. If you're in the disc space, it will open. We did it. Gosh. And like I said, the fact that this is able to work is maybe a miracle, but it certainly is a collaboration of a lot of good luck and good fortune, right? And good medicine. So we've got great anesthesia, the patient's comfortable, she's not tightening up her muscles, because if she was tightening her muscles right now, we wouldn't be able to get that thing in. So the fact that she's relaxed because of her anesthesia and pain control that Dr. Burndes has done a phenomenal job on, that has allowed me to enter that disc, because now the only resistance to entering is the disc itself rather than the muscles. And of course the facet joint is also a barrier to entry, which we can't do much about the facet joint. They're pretty stuck down and scarred up from arthritis, but at least we can eliminate the muscle compression and tension as a main source of resistance to entering the disc space. Let's go see what we've got. Again, we're going to have a very collapsed disc. There won't be much disc left. Any questions from our audience? A lot of bone spur.
No, sir.
By the way, if you're watching this surgery on March 1st, 2022, you may be watching it live. We're streaming it live on YouTube, Facebook, Twitter, and not Instagram, but LinkedIn. And if you're watching it live, you're welcome to ask questions. That's why we stream live. We want people to be able to ask us questions that I can hopefully answer for you. And it doesn't have to be questions about this particular surgery. It could be, are we okay, Crystal? It could be questions about anything in spine. All right, we got some bleeding end plates. Let's get a grabber. There's the annular tear there. And I'm gonna try to see if I can see that better. So there it is, that's the source. I'm gonna back out just a little bit more. There's a lot of inflammatory tissue right up there. Laser. This will be another very quick disc to fix because there's not much disc left. And there's the area that I'm trying to fix is very small. Small but very painful. And calcified. It's amazing what a tiny little thing like this could cause so much pain. Yep, look at that, cleared up. Beautiful. That's it. I mean, my gosh, huh? So little. Ah, a little piece of herniation. Get it out of there. It doesn't want to go. I think it's out now. All right, so that's it. Another 30 seconds here, we'll be done, and then we'll head over to L5-S1. Let me just see. That is a bone spur, if I've ever seen one. Pretty good size one. As you can see, the laser, or the bone spur, I should say, is no match for the laser. Has broke that bone spur up in bits and pieces. Laser is able to melt steel quite well. And that's pretty much right there is the last I've got to do, and we're done. How is she? Good. That's it. I don't see anything lateral. We're done. Last one. Scope off? Nah. Mm-hmm. All right, I'm taking this thing out. Last disc. Well, I apologize for the late day, everybody. I think it was a bit of an unusual one, but I'll tell you what, you all can have a break next week. Okay? You gonna be all right? Anything I can do to help? All right. So, huh? Is there nobody? All right. Shot? I understand. Well, this is clogged up. You have another guide wire? Hold on, Luis is gonna try. Yeah, I would grab it anyway. I wouldn't shove it in further. I wouldn't shove it in. I would do backwards. Just get an x-ray, let's see where we are. So we're gonna have to do the same thing here at L5-S1. We're literally gonna have to navigate with the guide wire down, and then we're going to plant the tip of this dilator right where the disc is and try to open that disc. Well, the good news, Crystal, this is the last one, so we're almost done. Shot. And then Thursday will be an easy day. And then next week I won't even be here, so can get some rest. Shot. Yeah. Where's the guide wire? Shot. This is definitely out now. Hold on. I've got to try to point it up a little bit. Shot. Let's get an AP and see where we are. That facet joint is pushing my dilator down, which is probably why we had trouble the first place getting the needle in the right spot. So her arthritis is literally pushing. Let's go to a, yeah. Okay. That arthritic joint, you see the bone right there, right next to the tip of the dilator, just medial to it, pushing it. Let's go with a lateral. Shot. All right. I like to be a little more north. Shot. It's just not wanting to go. Shot. I'm trying to cantilever the tip of this dilator to aim up by cantilevering it off the iliac crest. It seems to be working. Let's go with another AP. Crazy what I have to do, huh? The jimmy rigging, the finessing, the finagling.
I'm watching all of it.
It's just
I'm taking it all in.
all these years of doing this, it's just never been easy, you know?
Right.
I wish there was an easy one. Lateral. You know? But the reality is most of the patients with disc pain let it go a long time, years. Their spine collapses down because they've blown the disc out. It dries out, collapses, and they start twisting and they get facet arthropathy, and it just becomes a big mess. And it's not the patient's fault because they don't know any better. Shot? Yeah, somehow. Shot. Shot. Let's get an AP just to make sure. She okay?
Gonna give her a little more medicine.
I gotta go more medial, lateral. Well, I think it might have just done the trick. You're definitely forced lateral in the disc because of this facet. Shot? But at least we're in the lateral part of the disc, so we can at least get to that tear. Shot? That's about as much as we can do. All right, Luis, let's make some magic. Yeah? You think so? No, please tell me. All right, let me try something here. I got an idea. All right, now try it. I may have to give it another whack. No, yes? No? Come off? Now try it. So what I'm doing is I'm hitting the dilator in a little further, and that's freeing up the soft tissue that's stuck between the dilator and the tube. No?
I mean, you can try.
So I'm just giving it a millimeter tap just to free it up from the soft tissue. Don't tell me we're gonna destroy 2 tubes. You what? Is that a bigger grabber?
No.
Let me tap it a little more. See if I can get it to dislodge. That should be good. Shot? Yeah, I definitely moved it in. No? Oh, is it? No?
Yeah.
You think so?
Yeah.
You want the thing?
I think it's working.
Here. We may need a bigger. All right, let me have a bigger vice grip.
Luis, maybe walk around and go on that side. Over here? Yeah, let it come and pulling the way it can get in.
Come on over. Come on over.
Maybe move the X-ray to get in there and just, I'm saying pull it the direction it went in.
It's not a bad idea. I love that positive thinking. I'll hold the tube. You focus just on that. Twist it. Oh, teamwork makes the dream work. Dude, great job. Great job. That's the dream team right there. That's awesome. Huh? Luis, we got to try that next time. It's all about strategy, you know?
You gotta pull the way it went in, you gotta pull it out.
He probably gave the patient a little extra medicine too. Yeah, just to make you look good. All right. All right, so let's go ahead and run the video on why the Deuk laser disc repair versus fusion, which is the alternative for this lady. Fusion of the spine.
A comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long, In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery.
Time to remove our tube from the bottom disc that we just fixed, which is L5-S1. Was not an easy surgery by any means. It was really the hardest of the day. But we were able to get in and fix all 3 discs, which I was a little bit concerned in the beginning because I couldn't get the needles into the L4-5, L5-S1. I only got it to the back of the disc. So once she was asleep, I was able to get the dilator in to the disc through the tears with her being asleep and relief. But yeah, the only one we actually did a discogram was 3-4, and it was a 10 out of 10 pain, and it was the kind of pain she gets every day. So I think she's going to be happy with the results. She may have some facet pain. This incision was a little bigger. The reason why we're at about 1 centimeter for the incision is because when I went in through the original incision right here, the trajectory at L3-4, I could not get it to go across enough. So I went wider and I was able to come across under that hypertrophied facet. So basically I had to make the incision a little bigger to get under the facet. But in the end, we got it all done. My team did a great job. Everybody helped. And it was a long, fun day. Thursday, we got 2 carpal tunnels. So if you're interested in watching, it's not spine surgery, but we'll try to broadcast those cases. If you have questions, type them up. Don't forget to visit your app store to download the Deuk Spine Institute app. It's free, costs no money. We don't do any advertising. It's just information to help you. If you know somebody with back or neck pain, you want a free MRI review, go to mri.deukspine.com and we'll do it for you. I spend Fridays doing free MRI reviews all day. Estimated blood loss, 2 mil. No complication. Go ahead and type up your questions now, and I'll be happy to answer them for you. I'll be there in a couple of minutes.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute. How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your
back. Hopefully you're hearing me this time. I would sign you all, but I don't know sign language fluently. All right, I'm Dr. Deuk. We've just finished with our last surgery for the day. And this lady came to us with chronic back pain coming from L3-L4 4551. If you notice during the surgery, we were taking x-ray pictures of her spine from the front straight on and then also sideways. So we call this the AP lateral views. There's two views. AP is front back, anterior posterior, lateral is lateral. And the problem with her spine was multifold. She had a lot of issues. Number one, see how tall the disc is right here? That white thing is the disc. And with her case, she had such severe degenerative disc disease that the disc collapsed down. Like, so that it was almost, really it was bone on bone in certain places. But she was still having pain from the back of the disc and the annular tear. She also had a twisting of the spine, so that kind of closed down that one side, but opened up the other side. Unfortunately, the side that was closed down, or the side we needed to fix, was narrower. The other side was more open, but that wasn't the side where her pain was. So we were able to get in and open up the space a little bit for the nerves, remove some of the herniated material and bone spurs, and I hope that works for her. Anything more than that would require a fusion surgery. I've done these patients for years with these kind of bad collapsed discs and arthritis and degenerative disc disease and twisting of the spine and arthritis of facet joints. And I've done these laser surgeries for years, and surprisingly, they do really well. You wouldn't think they would. You'd think they need to be fused or corrected with their deformity, like correcting the scoliosis and straightening the spine out, or correcting the kyphosis, or flat back deformity, and doing osteotomies and reconstruction of the spine, which is what I did for many, many years before I did endoscopic surgery. We would basically put in cages like this one here to jack open the disc space and put lordosis back in, which is a backward curve. Put in screws and rods. I would even do osteotomies called Smith-Peterson osteotomies, cutting out the bones here, the facet joint completely, so that I can mobilize the spine. So after, for a period of time in my career, for about 15 years, 16 years, I was doing fusions as much as I was doing endoscopic surgery, side by side. And I would offer pretty much everybody endoscopic surgery or fusion, and some people would choose fusion for insurance reasons. Some people would choose endoscopic because they didn't want to have a fusion. But their conditions were the same. They had herniated disc, bulging disc, annular tear, scoliosis, stenosis, facet arthropathy, radiculopathy, neurogenic claudication, basically all those same back pain and leg symptoms, like I like to simplify it. And I found that the patients that had the big fusion surgeries and the patients that didn't and had the endoscopic surgery, they were doing, like with respect to back pain elimination and leg symptom elimination, identical. So whether I did the big whack with the big incision and long recovery and pain and suffering after surgery versus the endoscopic, the elimination of the back pain, the elimination of the leg symptoms was the same. It was around 98% for both. And then the difference was the endoscopic had a tiny cut. They went home the same day and basically went on and did very well, whereas the fusion patients, they have a much longer recovery period. They have to take narcotic painkillers, etc. So I feel very comfortable treating pretty much anything from an annular tear with a small disc bulge all the way up to a degenerative disc, spondylosis, stenosis kind of thing with deformity, and getting the same results with the big surgery. All right, we'll take our first question.
Yeah, this one comes from Chris. If a patient has spondylosis with a disc protrusion and can carry out the laser disc repair, will that eliminate most of the pain? Also, this is the second part. Can patient live with spondylolysis with fusion, providing the disc is the main source of pain?
All right, so great question from one of our viewers. They're asking about patients that have a problem with the disc, and that problem is basically something called spondylosis. Spondylosis essentially means arthritis of the disc, and you kind of see changes in the disc. You get a collapsing down of the disc, so like a deflating of the disc, where the bones start settling down on each other, just like the lady we just did. You get bone spur formation within the disc and around the disc at the back, near the neuroforamen. So you get bone spurs, collapsed disc, irregularities of the end plate, a lot of basically scar tissue and calcification. So the question is, can a patient have that and do well with the laser surgery? Absolutely. That's exactly what the laser surgery fixes. Now, the laser surgery will not reinflate the disc and make it look normal. The disc will never be normal looking again, but the laser surgery gets rid of the pain from a herniated disc with spondylosis. And then the next question, was about spondyloptosis or spondylolysis.
The second part of that question was, can patients live with spondylolysis?
Spondy with a spondy,
With
without
fusion.
fusion,
Exactly.
providing the disc is the main source of the pain. Yeah, so great question. A lot of people have a slippage of one bone on the other called the spondylolisthesis. And, you know, there's different kinds of spondylolisthesis. If you slip forward, it's anterolisthesis or anterior forward. If it's slipped backwards, it's retrolisthesis. You can also have a lateral listhesis where you slip to the side, and that's what happens in scoliosis. So there's forward slip, back slip, side slip. So anterolisthesis, retrolisthesis, scoliosis. Long story short, absolutely. I fix people all the time with anterolisthesis, retrolisthesis, lateral listhesis, using the laser surgery, getting rid of the pain, but not doing anything about the slippage or the deformity. That's the whole point of this program, is to teach people you don't need to have, you know, corrective surgery of your spine, big surgery with screws and rods and osteotomy or artificial disc to get rid of your pain. It can all be done endoscopically with the Deuk laser disc repair. That's because I am actually targeting the tiny little exact source of pain. Those other surgeons are just, it's like a shotgun approach. They don't know what's causing pain, so they're just fusing everything, you know, and hoping you get better. And a lot of times patients don't do better. So that was our only question. It's been a long day, and Kevin's done an amazing job. Good job, Kevin. You're awesome. I am going to broadcast 2 carpal tunnel releases, kind of boring little surgery, but if you're interested, come watch. We're going to do that Thursday, and then we'll be done for this week. Next week I'll be in Europe with my son Arias. He starts his Italian and German F4 training with Van Amersfoort Racing, which is the same F4 team that Max Verstappen started with. And it's a Dutch team. They like him. He earned a seat on the team out of 160 drivers around the world, the best drivers. He beat them all out for that seat. I still have to pay for it, but you know, we got to go start practicing in Italy. We'll be in Misano. If anybody wants to make the trip, we'll be in Misano next Wednesday and Thursday. And if you know a sponsor, we're looking for a sponsor. Pop can't support it much longer. This is the last year that I can help them financially. So if you know somebody with lots of money that wants to sponsor a up-and-coming American race car driver who's got a lot of potential, let me know.